ค่ะแล้วก่อนจะเริ่มช่วงต่อไปนะคะขอประกาศ2เรื่องนะคะสำหรับทันตแพทย์ไทยนะคะเรื่องแรกคือเรื่องคะแนน CE Credit นะคะรบกวนคุณหมอนะคะเซ็นชื่อทุกเช้าของงานประชุมนะคะเรามีงานทั้งหมด3วันนะคะเซ็นชื่อตอนเช้าแค่รอบเดียวนะคะโต๊ะสำหรับเซ็นชื่อ CE Point จะอยู่ด้านข้างบูธออมโก้ที่เป็นบูธโค้งอันใหญ่นะคะอยู่ทางด้านขวาของบูธค่ะรบกวนเซ็นชื่อแล้วก็ลงเลขทอให้ชัดเจนนะคะวันละ1ครั้งค่ะแล้วก็ประกาศเรื่องที่2สำหรับท่านที่ขับรถมานะคะบัตรจอดรถที่เป็นการ์ดเนี่ยสามารถสแกนบัตรได้ที่ทางด้านหลังของบูธออมโก้บูธโค้งเช่นกันนะคะจะมีเครื่องสแกนอยู่นะคะแตะบัตรให้ไฟขึ้นเป็นสีเขียวแล้วก็เรียบร้อยนะคะขอบคุณค่ะ
Okay. So we're going to get started back because people start coming in. So we need to modify that final arch. All right. So if you do not modify the final arch, you're going to have problems, arch coordination problems. So this was a photo sent to me by email, and they had finished the case in 1925 steel, and look at how the arch was overexpanded. And they couldn't understand why they couldn't get the arches coordinated. Well, that's the Damon arch form right here. It's overexpanded. So they asked me what to do, and the answer was just let the teeth settle. So we just had a retainer put on the 2 to 2, all right, and let the bite settle, all right? And I said once they settle, then you can take your impression for a retainer, right? But if you keep a steel wire in there long enough and you don't modify the arch, you're going to get that arch. You'll get the Damon arch form, right? But it's not what you want. You want the body to establish that arch form. So this is an exercise just to show you how we do it. But we do this right in the mouth on the lower arch, all right? So what we do is let's just pretend that this is the lower arch form in the patient's mouth. My staff cuts the wire based on the size of the last wire we had in, which is the 1825, right? And this is the lower arch form. We drop the wire on there, and then we modify it according to the shape that we got. Most times, I'm going to constrict the wire down a little bit. That's typically what I do. Constrict it and toe it in a little bit. I would say that's the adjustment I make 95% of the time, okay? So you need to modify that arch form. And then we use this as our final arch form, upper and lower. All right, upper and lower. So take a look at this. Look at the lower arch form. Went into crossbite. That's because the 1625 steel wasn't modified. All right. So take a look at this arch form. Take a look at the finish when the alveolus is modified. And look at look at the shape of those two arches. My clicker's going a little crazy. Now, who would have guessed that that was the arch form that would have been established? Okay? So that's given to us by the muscles. Now, should we always treat to the original arch form? That's what I was taught in school. When I was in my program, I was said we got to treat to the original arch form. If we had more than 5 millimeters of crowding in the lower arch, we were taught to extract. All right, but Melvin Moss said, no, you should not be doing that. So there was this conflict in my mind coming out of school that I should be extracting in these cases, and Melvin Moss says, no, you can upright teeth. Don't treat to that original arch form, right? So this is Karina. We showed you her earlier today. How would we treat to the original arch form here? All right? So let's look at our slide again. We need to let this functional effect occur. We want to keep our forces light. And there's two things that are important here. Disarticulation and early light elastics in this particular case. So how would you establish an arch form for her? I don't know what arch form she should have. I got a whole drawer full of charts in my office from Andrews, from Ricketts, which one would you pick? It's just a guess, right? So let's look at Karina and see how we treated her. And we're going to show you how the arch form is established. Of course, my link isn't going to work there, right? Okay. So I've got to escape from this. Okay. So Karina is a class 1 malocclusion with severe crowding. You saw that, right? But she's also got very constricted arches. She's a bilateral crossbite. And to add to the problem, she has anterior root resorption. She fell as a little girl and fell on her front teeth, all right? And the result was, again, obviously why when she fell, she hit her front teeth. Look at that arch. Looks like an arrow. So she fell and she injured her teeth. And you can see resorption there. You can also see it on the ceph. So how would you deal with that? Well, that was a big concern for me in conventional mechanics, perio cases and cases with root resorption, because the prognosis is not so good, is it? All right? So we absolutely inform consent the patient that there's a possibility we're going to lose those teeth, even with light forces, because she's got about 2/3 of her root gone. All right? Look at her profile. Not much of a smile. Okay, so let's talk about the wire sequencing in a case like this. We are not going to go 014 to 1425 in this case. Should be pretty obvious, right? So already we're going to modify our arch form. So in severe crowding and constricted arches, we're going to stay longer in the round wires, minimum 6 months. Sometimes I've gone 9 and 10 months in round wires, right? So in addition, we do that in perio cases with root resorption. And take a look what happens with 3 round wires over 6 months. This is the day we put the 1425 arch wires in. The only elastics that we use in this case were crossbite. Okay? So we started with Quail crossbite elastics for 6 months. I want you to also look at the turbo. All right, so we'll take a look at that turbo. It's unilateral. We engaged all these teeth. Now, why would I do that? I know there's a lot of binding friction here. Okay? I want you to start thinking about, look at the retroclined incisors, look at all the crowding. When you see that in a case, what does that tell you about the muscles? Okay? Let's look at the occlusal shots. Look at all this constriction. Remember, she's in bilateral crossbite. The only elastics we're using are little shorty 2-ounce crossbite elastics, because I know that she's got powerful buccinator and a powerful lip because of what happened to the dentition. So now those muscles become my ally in treating this case. I can push against those muscles. And by the way, who would have figured that this arch form would change to this arch form in 6 months? How would you know that? Suppose you didn't have to know that. Suppose you just let it happen. Right? Let the muscles dictate where the arch is going, not us. It's not our job. Passive self-ligation allows the muscles to impact the case. Here's the unilateral turbo. I put that on because she wasn't going to hit anterior turbos, right? Because her teeth were protruding with the narrow arch, right? And when we put this turbo on, we will switch from side to side. You saw 6 months of photos, but we move this back and forth, all right, when we have to leave it on for a long period of time, okay? So let's talk about that disarticulation. Okay. Anterior turbos are needed in this case for vertical increase. But we can't get them on, right? You can't put them on the centrals. She's not going to hit them. She wouldn't hit the canines. They were too far out and up. And we couldn't put them on the laterals. So we put them on the molar. But it's a deep bite case. You don't want to put them in the occlusal. You do that in high angle cases because you want to control vertical. But here you put it on one side so you can let the vertical increase on the other side. And then move it back and forth if you have to. You don't want to leave it for a long time on one side because you start to get a cant and possibly a TMD problem, right? So you can move it. We just L-pop it on. It's easy to pop it off, right? L-pop, you know what that is, a self-priming etcher, right? Dry it, throw a little blob of composite. In this case, the blue is band lock. All right, so turbo can be here. So we're going to talk about turbos. We're going to talk about disarticulation in this sequence, right? Now, notice that we can change sides. This is not the same case. I'm just showing you some examples of turbos, right? So we move it from side to side if we have to. We disarticulate virtually every single case to facilitate movement, to allow muscles to have the greatest impact. Light elastics, crossbites in this case, started sometimes shorty 2 or 3, right? But in this case, only crossbite. Vertical control is essential. In deep bite cases, we want to increase vertical. In high angle cases, we want to maintain. We're not going to intrude molars with turbos, but we don't want the molars to extrude, okay? So we must control them. In really high angle cases, we have molar turbos on, and we do a squeeze exercise. We have them bite down, squeeze, hold it for 5 seconds, and relax. And we tell them to do that every 15 or 20 minutes when they're in school, listening to their teacher. If they don't like their teacher, we tell them to squeeze down and make a face. No, I'm only kidding. I don't want to get in trouble with the teachers. So we increase vertical in the low angle cases, but it's really important to control vertical in the open bite and high angle cases. All right, so there's our molar turbos, bilateral occlusal. And you see this is in an extraction case. Now remember, this is not our case now. I'm just showing you some examples of turbos. And there's another tip. We cinch the wire behind. Never cinch your wires tight in Damon. Even when you cinch a wire out the back, cinch it behind the molars to allow the teeth to move. If you cinch it tight, you're defeating the purpose of allowing muscles to impact your case. Okay? So molar turbos can be first molars as long as you engage the second molars. You can use a bite plate. This is Essex ACE material, all right, which is a combination of C. You must use ACE or A material because C will not bond. You can't bond to a C. That's the one that looks cloudy. It's more rubbery, right? So you must use one that you can bond to. So to jump an anterior crossbite here, we use a posterior bite plate. You can use metal or composite. I used to use a lot of metals, and now we use composite, okay, because the composites are strong enough to hold. Okay, so you can see when we disarticulate, it gives teeth room to move. Look how these teeth uprighted on 014 arch wire, all right? 9 weeks. One thing you must be careful of is that they don't bite behind the turbos. Sometimes they're giving you a pseudo bite. They're biting forward. If they get behind the turbos, that's going to cause a problem. So you must make sure that they are biting on the turbos, or you put the turbos on the canines if they're not going to hit them, okay? Or the unilateral molar. You can put them on laterals. Here's a mutilated case. Remember what I told you? Get everything class 1. So we're working to get class 1 anterior and class 1 canine. And look how crazy this is. How are you going to think about treating this case unless you get everything to a class 1 position? So this is going to be a big implant case. But to get this, everything together, you've got to control class 1. This is Karina. We can bond the E's, and we can start to get the development of the arch. If you have deciduous teeth present when you start a case a little early, bond them, because that's going to help move that bone with the teeth. We bond baby teeth quite often, right? Because I got to get this case moving, and you can see one of them fell out by the time I got to 6 months. But you want the bone to start moving with the teeth. You want to get the alveolus developing. Well, it's all right to bond baby teeth. We bonded both lower molars. You can see again, one fell out. Remember, I compared this to the lip bumper case. Look how nicely these teeth align in 6 months. Okay, so unilateral molar turbo, switch them from side to side if you have to stay for a long period of time. 11 months in, she's looking pretty good. And for most of the time in this case, I'm going to be waiting around for teeth to erupt. I got second bias to erupt, and I got second molars to erupt. But I opted to start this case because she was so severe. And I did tell the parents that we're probably going to lose her front teeth, because she has severe root resorption. So, I mean, it's crazy to think that I would do this, right? Bond those teeth, but you must informed consent them. Why do I do that? If we're going to have to lose those teeth and she's going to need implants, to put implants, you need to have bone. So you're going to use those teeth to at least create the bone you need for restorative. Right? So yes, that patient is at risk for losing the teeth, but you can't restore if you have a pointed V-shaped arch, right? How are you going to get implants in there? So it's a trade-off. All right. So you must inform consent that there's a possibility of losing the front teeth. And you explain why you need to do it. Okay, so far, so good. So periodically, we're going to monitor for root resorption. And at this point, we don't have any additional root resorption. Even though those teeth were so severely rotated and crowded, remember, 3 light wires, no root resorption. Now, I'm going to give this away right now because we didn't lose the teeth at the end of treatment. She got to keep them. She still has them today. All right? So the light forces, don't be afraid to tackle these periodontal situations. I don't know, people probably have seen a case I showed here. I showed it all around the world, and I was in Manila. I showed it in Indonesia. A young lady named Pooja, who was of Indian descent, that had severe periodontal juvenile odontitis. We treated her without losing any teeth. Okay? So light forces are a big deal. They really are when it comes to perio problems and root resorption. Okay? So you can see the root resorption is still there, but no worse. Now, I don't take Panorexes at every visit to check, nor do we take PAs. But you can certainly check the mobility of the tooth, right? Yes?
Wire for this case?
Did I use a bigger wire?
Yeah, 1825.
we're going to go through the same sequence. Once we get through our round wires, it's 1425 and 1825. Now, there is a time to modify the 1825, and we went to steel in her case. All right? But there is a time to modify that technique. Let's say we have a Class 2 Division 2 case. Why would we go from round wires to 1425, all right, and then we go to 1825? Well, if it's a Class 2 Division 2 and we have high torque requirements, why not throw a 20-degree torque wire in there in addition to high torque brackets? So at that point, we would modify it. Same thing with Class 2 Division 2 in the lower arch. Don't we usually have a bi-level occlusion? All right, so why not, instead of an 1825, put a reverse curve arch wire, 16 or 1725? So common sense approach to modifying the wire sequence, even with root resorption. Okay, but we're going to be careful with heavy forces. Now on Friday, I'm going to talk a little bit more about that. And because that's how I found why people were having so many problems. It was an accident. As everything in orthodontics happens. Most of the stuff I learned over my 40 years of orthodontics was by accident or mistakes, right? Something happens and you go, how did that happen? And you have to figure it out. So we're going to talk about those things on Friday, okay? And we'll talk a little bit about it today. There'll be some cases where, all right? Now, here's another accident. See this accident right here? I chained the bicuspid because, remember, the baby tooth fell out, all right? And I put a button on this tooth, and I chained it to move the bicuspid. Well, in 1997, everybody's done that, right? Has everybody put a rotational tie on a tooth when it first erupts and is severely rotated? You put a button on and well, guess what? I did that so many times in my 20 years in conventional mechanics that when I saw Dr. Damon's stuff, I understood why his teeth were moving so quickly. Because there's no friction here. Zero friction. And that tooth, watch how it spins. So understand, and this side we put a button on just to erupt the tooth more. So we can cheat a little bit to help us get the teeth in faster. All right. Now, again, second molars are beginning to erupt. All right. I want you to watch this bicuspid. All right, watch what now you see what the chain is, right? It's a 3-chain. I actually have a skip in between. Because I don't need any force to move that tooth. Don't need a lot of force, right? The skip is there. So let's watch what happens to that bicuspid. The very next visit, I can bond the bracket on it. Same thing over here. We erupted the tooth enough to get a bracket on. Okay. Now how crazy does that look? What's crazy about that picture? I put metal turbos on the 2 front teeth that have no roots. Now, I got to tell you that. I just did that because I could get turbos on, right? I went home that night, and I woke up about 2 or 3 in the morning. I sat up in bed, and I said, you jerk. I don't believe I did that. I just put turbos on those front teeth. There's no roots. How stupid was that? Well, guess what? We called that patient back in. We monitored it. We took PAs. Never had an effect. So we kept them on. Metal turbos, not composite turbos. So again, it just disarticulates them. All right? But when I did it, I wasn't thinking. Because it's what I routinely do. I could get to the anterior turbos, and yet there still was no side effect. You'll see. All right? Now, here's the tooth. You got to really look at this. Look at where it's at. This is a 3-chain stretched before we put it on. Not only does the bicuspid rotate, look at the mesial marginal ridge. It buries. If that doesn't tell you that light forces are better for teeth, how could that bicuspid move that much and tip like this? Because there's no friction, zero friction. It's just floating out there. So when I was looking at this stuff in 1997 and watched Dr. Damon's teeth move so different than my teeth moved, I got it. It just made sense to me. It's friction. Friction kills us. And that's a perfect example of what I was looking at, how I could move it. You could move a tooth like that. And when I show you stuff on molar uprighting, you won't believe it. Right? So quickly to move these teeth. Vertical elastics. And you see, I kept the metal turbos on. We took PAs. But remember, I had an informed consent. But I thought myself, boy, that was really dumb to do that. And then I found out it didn't have any bearing on the case whatsoever. So I would tell you, don't worry about putting turbos on, because they don't bite and squeeze on turbos all day long, like we just talked about, you sitting with your jaw relaxed and open. Most of the time, their teeth are open. It's only at night that we worry about keeping them from grinding their teeth. Now, here's another little trick. We put separators in the 7s to help them erupt faster. We put them in one visit, pull them out, let the teeth erupt so we can get brackets on them. So we call those separators to lift. Just put them in there, pull them out the next visit. Because I want to get out of the case, and I'm waiting for teeth. So we finally get to bond those 7s. The upper is just beginning to erupt. I like to have my 7s bonded all the time, but it's essential that you get the lower 7s bonded. The uppers will usually erupt into place if you have function on the lower 7s. So I don't like getting out of a case unless I have those lower 7s bonded. Okay? So you can see that expedited the process of eruption that I could get a bracket on. Here we use the half bracket, here we use the full bracket. She wasn't a very good brusher, as you can see the stain. We took the stain off when she was brushing good. I told her I wouldn't take it off until she started brushing better. So once her hygiene got better, we took the stain off and we finished her. Look at those teeth. All that crowding. And do those teeth look like they're flared? We'll look closer. How do those teeth stay that upright with all that crowding? Why aren't they doing this? Right here. Did I pull on her lips to find out how strong they were? Because I know how strong. I looked at her teeth. I looked at her models. Looked at her photos. You can push on those with a bulldozer. You're not going to flare them. Because how did this malocclusion happen? It's the muscles. Has nothing to do with it, right? It's the muscles. So those muscles become your ally in treating. You can push against them. They're not going to let those teeth flare. That's what crowded them up to begin with. And you can see these teeth are still too upright. I would have put a torquing arch in this case. I would have put 20 degrees of torque, except that they were root resorption. So I was so lucky at this point with turbos and no further resorption. I wasn't about to push my luck with 20 degrees of torque. Okay. Root resorption, initial, final, and I blew it up. And I tried, it's hard to see, but there's no additional resorption. We got a little burnout on the x-ray there. So I try to blow it up as much as I can. But you can actually see the outline if you look close of the root. Okay? Same thing with the SEP. Look at the SEP. You can still see the root side by side. So we lost no additional root structure. That's the magic, the miracle of light force. I mean, I absolutely thought I was going to lose those two centrals. I mean, But what's the risk? You've got to restore, you've got to create the alveolus to hold implants, so you have to explain that to the parents. You need that bone to ever restore her, so you've got to do it. There's no choice, but you tell them the risks. And with all that crowding to all this, and we didn't lose the roots. It's pretty amazing to me that that can happen. Now, could I have done that in conventional? In school, I was taught to extract in that case, right? 4 bicuspids. Serial extraction. What would I do to that face? Are you kidding me? Look at this. If I took out 4 teeth, I would have made her look like a denture patient with their teeth in the cup at night, right? How could you do that to that young lady, right? You can't. So that's the power of passive self-ligation. You can do things with light forces. Look at this. She's a little protrusive here because of where are those teeth, right? They're hanging out here. And she actually flattens a little bit. Can you imagine taking out 4 bicuspids and what she would look like? Yeah, she was sleepy. She is cute, though. She is a cutie. And she's so small. She's so petite. Yeah. So that's what we can do with light force. And like I said, the key is understanding the muscles and that dental alveolus. And what gives it away my link didn't work, so I have to close this out. I apologize. I don't know why that happened, but so we had the nerve to do that. I don't know if anybody was at the forum when Chris Chang said it, but I'm not going to say it. what it takes to do something like that. He called it big ones. Okay? But Chris can get away with that. That's what happened to our arch. That's alveolar modeling. What is modeling of bone? Is it growing bone? I don't think so. All I think is happening here is we are letting the genetic potential of that bone to develop. I don't care if she is 12 like she was or she's 24. It's still the potential of the bone to be there. The muscles collapse that, and until they stop breathing, we can change that. So you can do this in adults. I don't rapid palatal expand with surgery anymore. I do alveolar modeling. We'll talk a little bit more about that later. And how could you have predicted this arch form? That's the bad news. The bad news is how could you have predicted that? The good news is you don't have to. Because the body is going to determine what the arch form is. It's patient specific based on their muscles and function. Now, why can I say that? Well, see this case, she's 28 years old. She was treated with full braces 14 years before, okay? And she comes back, so she's got a little relapse. Her canines gone into crossbite. She had a little class 3 growth, post-retention. And she was treated by a reasonably good orthodontist. Now, what is relapse? Sometimes it's poor growth, sometimes it's poor function. But I don't believe relapse is our fault unless we start tipping teeth all over the place. If we tip teeth out there, then it's our fault. But many times relapse is not our fault. So we retreated her. Remember I said she was treated by a reasonably good orthodontist? Well, the reason I said that, it was because it was me. I treated her 14 years ago. And she came back, and I retreated her with Damon. Took 18 months, and it's not perfect. What I learned from this is what she said to me. She walked in and she says, I can't believe how different my smile is. And I didn't think anything of this case. It's a pretty, bland, everyday case. She says, I look at my pictures. I can't believe the difference. So I went back, and I sat down and looked at her final photos. Okay, well, it's not that impressive, right? I mean, it's okay. But then I looked at this, and I said, wow. So this is the arch form that I gave her 14 years ago with whatever chart I was using at the time, right? And this is the arch form that came out using Damon. Okay? Notice the uprighting of teeth, like Melvin Moss said. You see the buccal surfaces of the teeth here? You see less over here. They uprighted. That's where the room came. And notice that the bar is the same bar, except years later. Look at her lip posture. Profile, a little change maybe, a little positive, but nothing to speak of. But this is what struck me. Right? So when I went back and she told me how great her smile looked, I went back and looked at the records. And that's the arch form I gave her, and that's the smile that she got. This is the arch form that came out of Damon. What about that smile? Is that different? That's why I'm telling you, the good news is you don't have to worry about what the arch form is. You're going to let it happen. Let the muscles do it. Just be patient. And you're going to get this. She's the one, like I said, this is just a very routine, run-of-the-mill case. Until she said that to me, I really sat down and looked at the records. And I realized what she was talking about, why she loved her smile so much. All right. So it's about the new tool again, allowing muscles to impact the case, functional effect. I told you the lighter the forces, the better. And then positive periodontal response. Let's begin the journey that I call making the case for light forces. I don't have to show you the dentition, do I? What does that tell you about the face? Look how collapsed it is. Look at the width of the lips. You're going to see that in every case. You're going to see the change in the width of the lips. And yeah, there's the impact of uprighting teeth. Look at the collapse here. Look at this collapse. This is what gives it away. This is what you're looking at, the dental alveolus. Look at the buccal segments. Look at them leaning in. Know that this case is begging to be treated non-extraction. Know that you can do it in an adult dentition because all we're doing is altering dental alveolar bone. If you extract the molar, lower first molar, and what happens to the upper molar? It extrudes. Does the alveolus come with it? Yes. It's modeling. Right? Well, why can't we reverse that? Upright the teeth, because Melvin Moss told us we could do that. Look how upright these teeth are. That's where all the room comes from to straighten the teeth. It's modeling, not growth of bone. We're not growing bone, but we are giving them their genetic potential back, because that's what Melvin Moss taught us we could do. So tissue issues. I like that. Sounds good, doesn't it? Tissue issue. Not Kleenex. All right. Tissue response is much better with bone and soft tissue with light force. Worst case scenario, a tissue issue will remain the same like you saw in that case previous. But most of the times it will improve, and sometimes very dramatically. Okay? We'll see that all day long. Here's a perfect example. All right? What's the tissue issue here? We've got a lower incisor. That's very thin tissue around it, right? Thin biotype. But yet I engaged all those teeth. Again, looks a little crazy. Is that tooth at risk? Well, I would have never done that in conventional mechanics, but a little girl, which you'll see later, told me that I could do that. So we can look at coil force here, in this case. We're going to look at tissue issues. We're going to look at the arch form issues, and we're going to look at friction issues in this particular case. So let's look at This is, oops, sorry. My clicker is going a little crazy. But what's our friction issue? Why did I bypass one segment? Well, look at all the space we create for this canine. Okay? By using a long coil from the molar to the incisor. Why does all this space occur? We're going to look at it when we look at this case. But part of it is that the coil creates a shield like the Frankel does and allows the arch to expand. If I were to bond these teeth right from the beginning, right, there would be too much binding friction, in my opinion. And we'll talk about that in a little bit. But look at the light force of the coil. Did these teeth flare? The answer is no. Don't use heavy coils because you will flare teeth. If I put the brackets on immediately, look at the wire. Look how severe the curvature of the wire, how much binding friction there would be. But binding friction is a factor. Now when we put the brackets on, you see much smoother slope of the wire. So let's look at Dan. Let's look at his case and see how and why we treated that with one buccal segment bypassed. Hopefully this link works. There it goes. It's working. I don't know why that warning comes up, but all right, so this is Dan. Here's what he looks like. Initial pan, he's getting a root canal done in that tooth. Initial ceph. So he's got good face. He's got a good skeletal pattern, right? A lot of crowding. So how do I want to treat him? All right, but we got to worry about this incisor, right? Well, at this point in time, I don't worry about that incisor, but you should be. But you're going to understand why when we look at some cases, what happens to the tissue. So he's got a good face. He's a little bit class 2 in the profile. I thought about a Mara to treat him, but I decided to do it with braces and elastics because I had so much crowding. I would have to unravel all those teeth anyway, right? So we put the brackets on. I didn't rule out having to use a Mara in this case. I don't know if everybody knows what the Mara is, but it's a mandibular anterior repositioning appliance. It's a Herbst hybrid. And we advance the jaw just like Herbst, okay? But it's more like a twin block because we don't have any connection. We don't have that telescoping mechanism like we did with Herbst. So that's my choice, my appliance of choice. All right? So we definitely got a retroclined incisors. All right. 2.5 months. So look at the tissue. Any negative response? The answer is no, but no positive response either. Right? But what I'm showing you with the arrow is that that coil is so light that the teeth are not flaring. So when you activate the coil, it should be a bracket to a bracket and a half when it's 2x4 like that. Don't overactivate it. So there's our bypass coil. And look at the response here. Look how much space develops for that canine. Why did I do that? Well, number one, I create a shield to let the arch develop. Look at the molar. Do I have to distalize that molar? Or do I have to just rotate it to gain all that space? So that's why you got to look at your models and your photos. So I chose to go with the bypass here because I didn't want to create binding friction. I wanted to let that arch develop and the molar rotate. So we gain all that space. And look at the bottom. Look at all the arch length that develops from uprighting of teeth. And the incisor remains the same. So, simplified biomechanics. A simple coil does all that work for us, just bypassing teeth. And now you see when I engage the teeth, how nice and easy the slope of the wire is. When you look from the occlusal, look how much space. Look at this. Space here. I mean, This is 6 months before I put the brackets on. And I essentially don't have any crowding anymore. So just let it work. Remember, we're always trying to make things happen. Let it happen. Light class 2 elastics. So at this point in time, we're playing around with these light elastics off of copper night tie wires. This was not workbook. This was not textbook, right? Well, we started playing around with light elastics, and light early elastics were born in these early cases. Specifically, that's not me, right? Okay. All right, so we use a light elastic off the, from the molar. This is a Parrot, 2-ounce Parrot. And I told you earlier that I don't use much more than 2-ounce elastics in most of my cases. Sometimes go to 3. Now, here's a mistake. This is the arch form thing we just talked about. That's an arch form, Damon steel, that was not modified. And guess what happens? Goes into crossbite. So you must adjust the arch form to what you're given, or the steel wire will take it and put it in crossbite. So I've heard many people tell me that they have problems with posterior crossbites using Damon. And I will guarantee you, you're not modifying your arch form. You're just putting the wires in as you take them out of the package. So just what I showed you in the sequence before, you need to modify the arch form to what the patient has given you. Very important, or what you're going to have crossbite problems. Most times I have to constrict it and toe it in. And that's what I do to my lower arches almost routinely. Narrow them down and toe them in. So I put sweep in that buccal segment because you want the second molar curled in. Okay? And that will give you 9 times out of 10, or 95% out of 100. It's going to give you a good arch. So what do I have to do? We're going to do our repo visit, and then we're going to adjust the arch form. We're going to constrict it down, and it doesn't take long to get us back into position. I coordinated my arches, all right, and we're out of the crossbite. So again, from November to February, we got back under control by modifying the arch form. That's what we did. Okay? Because this is the Damon arch form. This is what you need to do most of your cases. 96, 97, 98% of the time. That's the bends I'm making. Constricting it and sweeping it. Okay? Simple exercise. That's our repo visit. And I also reshape. We're all dentists, right? Can we take a dime into a tooth? So I don't leave that chip there. I don't send them to restore that. I go in and do it myself. And I don't charge them. They love it. And you can see the tissue here stayed about the same. That's the guarantee I will give you. If you stay with light forces, when you have a tissue issue, oh, I love that tissue issue. Sounds good, right? You have a tissue issue, I will guarantee you that if you stay with light forces and use the right torques, we're going to talk about positive torque, which means lingual root torque or labial crown torque, whatever way you want to think about it, tucking the root into the bone, the tissue will either stay the same or it will get better. Okay? Every single time. So we finished him in 21 months. And look at the tissue. Still thin, but he's got a little bit of attached gingiva, but still a thin window, right? But it didn't get any worse. So we're going to monitor him for a graft. Now, in conventional mechanics, and I know many of you do this, we used to pre-graft. I used to send him to a periodontist if I was going to try this non-extraction and do a graft before I started treatment. Well, I work with 2 really good periodontists, and we never do that anymore. They want me to tuck the root in before they do a graft, so they get a better result. Okay? So we're going to tuck that root, and we're going to monitor him in retention for a graft. Wisdom teeth, we're going to order those out. We'll see him back in retention. Final pan, look at the root parallelism. We'll talk about bracket placement this afternoon and how we get that. All right, so the upper incisor was at 104. We torqued it to 107. Lower incisor was 88. We moved it forward to 100. In a low angle case, you can be at 105, 106, 107. Never in a high angle case. To get good lip posture, you need the incisor here for the lower lip. I showed you the extraction case this morning. You need the incisor back to get a good posture of the lower lip. Now, I flattened the smile arc a little bit, so we pay much more attention to that. But smile arc is dynamic. Remember that. The smile arc doesn't look as bad here in that smile. So when you look at a smile arc, don't always give yourself, a Z or a failing grade for smile arc. All right? Depends on how they're smiling. 4 years later, he comes back. Now, I don't know about the haircut, but his teeth look pretty good. All right? I think he looked better there than here. All right? So 4 years later, he comes back. So we're going to talk about stability. We're going to show you cases in retention. All right? Look at the tissue. What happened 4 years later? Did it get worse? Got better, right? Amazing. Because we tucked the root in. He never got a graft. It got better. The periodontist saw him once a year, did not graft the tooth. I don't care what angle you look at it. Look at the tissue. So when you tuck that root in, we're going to talk about positive torque on the roots. Now remember, you can take in our lower incisor bracket is -11, right? The low torque bracket. You flip it over. Any case with recession, you turn that over to +11. But what did you see in the first 8 weeks or 10 weeks? There's no torque involved in that, right? It's the transverse that allows the tooth to move in, not torque. Torque will not happen until we are much later in the case, in rectangular wires. So you can see the incisors did not flare from the torque, from the force. And who would like to build this wire versus using a coil? I did this in school when I was trained. That's the Burstone wire, if anybody knows. I bent those loops. And you know when you bend an arch wire like that and you put that in, they work great. But they always broke at 4:45 on Friday afternoon. Right? It was inevitable that that wire was going to break, and I'd be in the clinic till like 6 o'clock rebending that wire, right? So I learned not to do that. So I've been doing this for years. Light force is essential when opening up space. So that coil looks like it's really activated, right? That's only a bracket and a half. And it's a lot easier to do that than it is to bend that looped wire. The longer the coil, the lighter the force. So you want it, the lighter the force you want, the longer you have to make that coil. So that means you have to bypass more teeth. Night-tight coils are not super elastic. So when you compress the coil, the force doesn't drop. It gets stronger. But never use high T coils. High T coils are stainless steel. You can't make the coil light enough with high T. You must use night-tight coils. Okay. So let's continue with the system. All right. The working phase is steel or TMA. Okay? Most times we're using steel. TMA Class 1 crowdeds, we don't have a lot of elastics to wear, we will finish in TMA. Finishing bends. Placing first, second, and third order bends for finishing as needed. Okay. Now, why did I highlight third order? You'll find out Friday. On Friday, we're going to tell you that I don't bend very many first or second order bends anymore. Because I will prove to you on Friday that most of the bends we make in arch wires are wrong. But most times we have to put torque in. And we're stepping up a tooth, or we're stepping down a tooth, we're stepping in a tooth, we're stepping out a tooth. Friday, I will prove to you that you should be torquing teeth. Okay? So, third order bends is what we need to do most of the time. All right? Why are third order bends better? We don't change the plane of the arch wire. I have residents, I teach my residents to repo brackets. Stop putting bends in wires. They still bend wire. Because they're anal. Because as orthodontists, we're all anal, right? We want perfection. What happens when you step down a central? The other one goes up. And there's a side effect on the lateral too, isn't it? So the visit comes back and says, oh, that central looks better. Now I got to fix the lateral. I got to fix the other. So it's an endless amount of bending wire. And it's the wrong bends. Again, Friday I'll prove to you that the bend should be torque instead of these first and second order bends. That's what kills us trying to finish a case. All right? We're doing the wrong bends. Okay, so in the final phase, most times we're bending torque into our TMA. I don't bend torque into steel wires very often. But I think that's too heavy of a force. But I do use TMA to put my torque in. And we use a lot of set wires. Set stands for superelastic torque. It's a trademark of Ortho Specialties. It's 20 degrees of torque in a superelastic wire. I use a lot of torque wires, pre-torqued wires. Right. Ormco has them, and they're in sizes, from lateral to lateral. So if you don't have torqued wires, 20 degrees superelastic wires in your office, get them, buy them, use them. And again, I'll prove to you on Friday why you need to use them. If you're not using selective torques, and if you're not using 20-degree torqued arch wires, then you're working too hard. Okay? Way too hard. So let's review the wire sequence. 013 or 014, common starting wires. And I usually will go through an 016 or 018 as a second wire. It's very rare that I use one round wire today. If I start with an 014, I'm most times going to go to 018. So I'm usually going through 2 round wires. The second round wire, I leave only 6 weeks. All right, so if I use a first round, let's say a really crowded or constricted case, I put an 013 in there, I'll let that run 8 to 10 weeks. If I go next to an 016, let that run 6 weeks. If I go to an 018, another 6 weeks. So I don't run those for 8 weeks. And then I go to my 1425. But it's always based on the case, reading and reacting to how your teeth are moving. Don't try and push it. Let it work. Okay? The 1425 is the workhorse of the system, the first rectangular wire. You should never be forcing that in. The second wire is the 1825. We let that for 6 weeks or so, depending on the case. And then we bring the patient back, take a Panorex, and we check our root positions for repose. Okay? We'll talk about bonding this afternoon. The exception are extraction cases. I do not repo, except for obvious miss. I do not repo brackets in an extraction case until I close spaces. So we've gone through our wire sequence. We're in steels. We close the spaces. Then we do our repo visit. Because you can't tell how much you're off until you close the spaces, all right? So that's the exception. Unless, like I said, if I have 2 brackets and I have one central like this, and one, obviously I can figure that out and change it, right? But you should see that early on. So as I told you before, I substitute at the 1825 for these 20-degree preset wires. You're going to hear me say the word set wires a lot. It just stands for super elastic torque. It's a trademark of Ortho Specialty. They were the first one to have the wires. Ormco now makes them, okay? So I guess it's a patent issue back then. But I buy most of my 20-degree wires from Ormco, with the exception of lower arch wires, because Ortho Specialty still must have a patent on the 28 millimeter. So 28 millimeter usually works better in the lowers. It fits. You don't want the torque to go into the canines. If you only have a 34, then take a burr and round off the edge of the wire where it goes into the canine. Don't let the torque go into your canines. It's only for the anterior, okay? So 1925 stainless steel with post or locks for treatment mechanics. And the lower, as I told you, typically 1625. The alternatives are TMA. And you heard Colin talk about how we're getting more back to steel because we get better arch forms. So again, Stuart Frost is talking a lot about that. And that's one of the things we drifted away from. Drifted away from going to the steels, using a lot more TMAs, and we're now drifting back towards steel because we get better arch forms. All right, 19 or 7 now. Every time I go to the lower, I rarely use a 1925 in a lower, even TMA. I use 1725. Again, because of inner bracket distance. All right. So this is where we take a pan, check the root acculation, and we reposition brackets as needed. Okay? Finishing cases with a low force friction appliance. It always begins with good bracket placement. We'll talk about that after lunch. It's a precision appliance, and errors show up early. Now, just because I told you at 1825 we take a Panarix, we do our repositions, if you have an obvious mistake, change it. Don't keep moving a tooth out of position. If you pay attention to detail, you're going to be much more efficient. So, look at this bracket. Everybody in the room knows that that's wrong. Which way is the root going to go? Mesial, right? Now, so do I want to leave that? The root's going mesial. We know the root's got to go distal. If I continue on to 1825, I just keep making it worse, right? So when you see an obvious error, pop it off and reposition it. That's what I did. Now, that bracket placement, who did that? I could tell you my son, but I did that. Right? Maybe I didn't have my second cup of coffee. I don't know. But nobody's perfect. I mean, I can't believe it. Maybe my assistant hit it with the light, right? I can blame somebody, right? But nobody's perfect. But when you see an obvious mistake, change it. Change it early and quickly, because you don't want to keep moving the root mesial when you know you want it distal. So don't hesitate to pop a bracket off. It takes no time at all. So we got pre-torqued arch wires, like I said, from Ortho Specialties and now Ormco. Those are set wires. I call them set wires. You'll hear me say that a lot. Ormco doesn't call them set wires, so that's a trademark. But it stands for super elastic torque. Then there's RC set. We have reverse curve with 20 degrees torque also. Now, think about this. The straight wires, 20 degrees torque, right? Here it is, right? Here's your straight wire. Here's the 20 degrees torque. If I put this in the upper, I have to flip it down, right? Because that's torquing the central, right? We call that positive torque. If I take the same wire and turn it over and put it in the upper, it's negative torque. All right? Positive, negative. So if your teeth are flared, flip the wire, put in negative torque. If you're too aggressive with your sequence, all right? Now think about this. Negative torque. All right, let's go back to Burstone. Who's a biomechanics guy? What? If we put positive torque in the upper, right, what does that do to the posterior? Constricts it. If we put negative torque, our teeth are flared, what does it do to the posterior? Expands it. So it encourages the transverse. So if you're a little bit flared with your teeth, don't bail. right to extraction. First, put your set wires in, negative torque, and negative torque will take the incisors, and you're going to watch this. All right, they're flared, and you're going to see, you leave them for 3 months, and you'll see this happen. If the teeth are detorquing, the bite will deepen. Okay? They're flared, you put negative set in, they start to detorque. That's your sign that it's working. If it doesn't work, then it may be time to extract in that case. All right, that's your borderline, right? Now the reverse, if you put a lot of positive torque wires in, what are you doing to the buccal segments? You're constricting them. In a case where you have a narrow arch to begin with, you better have crossbite elastics on to counteract that. Okay? It's biomechanics. Simple biomechanics. Positive torque is going to constrict your arches. You can't afford that in a narrow arch. Keep your crossbite elastics on. Okay? And if you're flared, negative set wires are encouraging the transverse. So it may get you out of a case that you've flared the teeth a little bit. And flaring is not the worst thing in the world. We'll talk a little bit about that too. It's a better alternative than extraction, as long as the flaring is not really excessive. Okay. All right, cases to be used. High torque requirements like the Class II Division II. Bilevel occlusal planes. Class II Division II. Put the reverse curve in to level that arch quickly. All right? You put the reverse curve in, you level the arch, take it out, and go to straight wire. Same thing in the upper. Once in a great while, I don't use a lot of reverse curves in the upper. Why? Creates a negative smile arc. All right? If you have to intrude teeth, when you come out of that, make sure you put a straight wire in and re-level, because you're going to create an ugly smile. Reverse smile arcs are the worst. Right? So you want to make sure that you level that back out. So classically, in the Class II Division II types, is where we're using those reverse curve set wires. Play in the system allows muscles to impact your case. So how much play in the system, especially for torque in the anteriors? We get proper torques on the teeth, and then we can use 20-degree wires. So we can add tons of torque, and it's all light force torque. We got high torque brackets on, we can add 20 degrees torque. If we have flared teeth, we can put low torque brackets on and reverse torque. Right? So remember in your sequencing that you can substitute those 20-degree wires on a case need basis. Okay? Class II cases, most times I have high torque on the upper anteriors, low torque on the lower. So I think when I set my cases up with selective torques, I think about the mechanics. Class II case, I'm going to be pulling the anteriors back, and I'm going to detorque them, right? So I have high torque on. And what happens to the lower? They're going to flare. So have low torque on. So counteract the mechanics you're using in the case. So when we script a case like this, this is an adult Class II. Right? And this was previously treated with upper bicuspid extractions. And what did I tell you we need on the canines? High torque. This is the reason why. You see the canines are toed in? Because that's what happens as we retract them. So you want to counteract that. So we have high torque on the anteriors, low torque on the lower anteriors because of the Class II elastics, high torque on the canines. And why we have high torque on that one? See the tissue? We want to tuck the root in. There's recession on that one, right? Crowding in Class II mechanics. Right? High torque on the canines to upright them, low torque on the anteriors. There's a finished result. 23 months. Take a look at the canines. Look how upright they are. That's how you get that beautiful smile. Now the incisors, look at the bite opening. That was done with turbos. You couldn't even see the incisors before. Look at how much those lower canines have uprighted. That's what gives you that beautiful smile. It all happened because we put the right torques on. Okay? Very important to do that. The opposite is true of class 3s, right? Low torque on the upper anteriors, high torque on the lower anteriors. Because we're going to tend to detorque them. Class 2 Division 2, pretty much high torque on the centrals, and I don't use standard anymore on the laterals. I would definitely use low torque on those flared laterals. Right? So there's a classic case, Class 2 Division 2. If you don't use selective torques, you're wasting time. A lot of valuable time at the chair. We'll talk more about this on Friday. Can we achieve more consistent finishes with selective torques? And the answer is absolutely yes. Take a look at those two cases. Do they look pretty consistent in terms of the finish? One was an extraction case. One was a non-extraction. I used to be able to tell in my photos and models which cases I extracted it just by looking at the anterior teeth. Today I can't because we keep our torques pretty consistent. So this was an extraction case. And this was a non-extraction case. Extraction was 25 months in treatment, but that was a class 3 open bite. And look at the finish consistency. And this was non-extraction. Side by side again, non-extraction, extraction. If you don't count the teeth in the buccal segments, you wouldn't be able to tell. In the class 3 case, I took out lower first bicuspids, upper second bicuspids. And that's typical for an extraction case in the class 3. So again, I'm not hung up on 4 second bicuspids or 4 first bicuspids all the time. You extract the teeth that your case needs. So we start with the face and work backwards to the teeth. It's always about this. All right? I love this composite face. I found this on the back of a magazine. I think it was on Singapore Airlines. You know, it's a composite face. You have Asian, black, Caucasian. You know, so it's a wonderful thing to look at. Then we look at the second thing we look at is the skeletal pattern. There's always a difference between a high angle and a low angle, right? We all know, for the most part, you can do much more in a low angle case than you can in a high angle case. The high angle cases are usually the bigger challenge, okay? But not always. Muscles. You got to look at the muscles. And most times, here's what people think. They look at the skeletal pattern, right? It's a high angle case, and they throw the baby out with the bathwater. Not all high angle cases have bad muscles. More tend to have, but look at muscles, look at the dentition. Look what happened to the teeth. That tells you what kind of muscles you got. The dental alveolus gives away the muscles. There is no button pulling between the lips or checking muscle tension. We did all that stuff for years. You know, it's not about that. It's about looking at the teeth. That'll tell you what your muscles are. If you have flared teeth and spaces, you have no lips. Right? But if you have constricted arches and collapsed arches, most times you have very powerful lips. Okay. So passive, how is it different? Right. It clearly reduces friction, and therefore there are different biomechanics. It is definitely a new tool. Friction equals resistance to movement. All right? So the resistance comes not in the bracket like that, because when we put two surfaces in contact and we start sliding the tooth, the resistance increases when we start moving it. If we tie them down, that's a tremendous amount of resistance. And usually there's side effects. So, okay, first bicuspids out, and look what happened to the anterior teeth as the canines moved down. They were high canines, upper first bicuspids, and the anteriors flared. So what's wrong with this picture? It's green and black, isn't it? You created friction. There's going to be side effects with friction. The literature consistently tells us that passive self-ligation has the least amount of friction. Self-ligating brackets produce least amount of friction. Article after article. All right? But here's the fallacy. If you read those articles, most times they are pulling a straight wire through a straight bracket. When we move teeth, the teeth tip. And at some point, you get binding against that bracket wall. So that's where we have to be careful with passive self-ligation. Yes, it is the lowest possible friction bracket that we have. But you can never get away from binding friction. There's always going to be binding friction. That's what you got to think about when you set a case up. So does friction and binding matter? Well, if you tie these teeth down, there's going to be side effects. You create a spring here at the canine. And that's why you get this. Right? Because the wire can't pass out the back. If the wire can slide out the back, you're not going to see those side effects. This is what you create here in the spring. Anterior component of force, posterior component of force, and believe it or not, the canine feels like it's being pushed up because the wire's stuck. Let me prove that to you. Okay, so watch this example. All right, we're trying to type it on down, and we have elastic ligation on these teeth, all right? We're going to take the arch wire out of the slot and let it go. It's stuck. The wire's stuck. It can't slide out the back. So what's it doing to the canine? It's pushing it up when we want it to come down. It's pushing the front teeth out. There's your spring right there. It's like you just put a giant coil in this arch. Okay? Wire can't slide. You got the spring. Now let's do it with passive self-ligation. Okay, so we open the door. We're going to do exactly the same thing. Grabbing the wire, pull it out of the slot. Let it go. What happened? The wire can slide. Guess what? When the wire can slide, there's less side effects. That's the whole key to the difference in the biomechanics. It's that simple. Getting that is that. So, when you have a case like this, and you put brackets on it, and you level, as long as the wire can go out the back, you will not see side effects, because it will not create more than 40 to 45 grams of force. That's what the literature shows us that the lips can withstand, 40 to 45 grams of force. If you exceed that, then you're going to get flaring of teeth, because it'll overpower the lip. So, if we let the wire slide out the back, we don't see the side effects. But yet, there's an article in the AJO that says friction's not the big deal. It all has to do with binding. All right, so this is, I'm not going to show you a lot of articles or tear apart a lot of articles, you know, because we're way beyond that today. But I want you to understand how biased the literature is. They're saying that friction, that there's no difference between passive self-ligation and elastic ligation. That they're saying that the whole problem is binding. It has nothing to do with friction of the system that we're using. Okay? So he uses, to prove this, he uses data from Articulo and Cusi's research based on 2125 arch wires, stainless steel, Nitai, and beta titanium. So they try all three arch wires and they measure the forces, right? So at 7 degrees angulation, the resistance to sliding was 80% binding. At 13 degrees angulations, the resistance to sliding was 99% binding. So his conclusion is that passive self-ligation doesn't matter. You can time with elastic because the whole problem is binding. He says friction was not an influence. Okay, so what's the two measure? I measured this with a protractor. That's a 10-degree deflection of the arch wire. So it's right between these two. All right, I want you to raise your hand. Everybody in this room, raise your hand. Who would put this arch wire in today if it was 2125? You wouldn't have many patients left, would you? Because you'd be killing them, right? Who would try and get a 2125 arch wire in that? But that's what he just used to prove that there's no difference between passive self-ligation and elastic ligation. It's nonsense. But you have to read the articles. You have to look at what they're doing. I mean, nobody in this room would put a 2125 in there. Nobody. Because you don't want to hurt people. Right? I mean, it's just, we're nice people, right? We're all happy orthodontists, right? Because we create beautiful smiles and we don't want to create pain. But how stupid is that to say we're going to put a 2125 in there? That's the wire we would put in, 014 or 013, and that's the wire he put in for a statistical study. It's crazy. Yeah. So the key elements, force and friction. All right. This is the article, this journal. If you get this journal, reference this, take a picture of it, because there are 2 articles on NiTi deflection, or everything you need to understand, and about friction. All right, we're almost at lunchtime at 12 o'clock, so I'm just going to cover a little bit of NiTi force deflection. But we have 3 force systems that we use mostly in the world today. Active clip, passive self-ligation, not a clip, and elastic ligation. Active clip is certainly better than elastic ligation, but when you put the clip and close the clip, you reduce the size of the arch wire slot. Okay, so once you hit an 018 arch wire, you're engaging the clip. So it does create more friction, and therefore more side effects. So first we'll look at the wires. The difference between if we flex a wire that's non-superelastic, I don't care whether it's steel, whether it's TMA, okay, or whether it's work-hardened NiTi. The more you flex the wire, the force keeps going up until what? Why did the force drop off here? Because we kinked the wire. If you keep bending a wire to some point, it kinks, right? So now the force drops off because you can't do it. But with a superelastic wire, when you flex it into these really crooked teeth, the force goes like this, whoop, and drops off. You get this drop off of force, and then in the literature, it says light continuous force phase. Now, what really confused me when I read Burstone's stuff is that he has this chart. And I said, well, what does that mean? Why does he have all those force deflection curves in there? Well, it's this. What he's saying is this one wire here has all these different deflections. This one the most severe, so that has the greatest force drop-off. All right, and then we have the littlest deflection right here between the 2 bicuspids, and we have a little drop-off. So every force deflection is represented by that graph in this case. That's all you need to know about wire technology. It's as simple as that. It only took me 2 years to figure that out. And I just gave it to you in 2 seconds. That wire is doing all that different stuff. So the greatest deflection of the wire creates the biggest drop-off in force. And the littlest deflection, this little deflection between the 2 bicuspids, is 4 times the force of this one. That's what the literature tells us. So in this case, 8 months in round wire before we went to the 1425. So in the literature, Burstone says that this force is only 7% of what stainless steel would deliver if we could deflect it without deforming it. And this little deflection here is 28%, or 4 times greater on the 2 bicuspids than on that tooth there. How great is that for the ligament? That's what we want, right? On the tooth that's most out of place, we want the least amount of force. And that's what we get with superelastic wires. Okay? The least amount of force occurs with the greatest deflection. But remember this. The more you deflect the wire into all these crooked teeth, on the other side of the coin is binding friction. So if the wire binds up, you can get side effects from that. That's why we bypass sometimes. That's why we put coils in sometimes. Because binding friction will kill us, even in passive self-ligation. So you have to, the biggest mistake we made early on in Damon is we thought because we had this light force wire, we could engage everything. Well, we found out we couldn't because they went like this. It happened. We got complacent. We thought we could do anything. And the wires behave differently in different bracket systems. So The question is, you can put these same wires in any force system, right? I've heard that guys from college, they tell my residents, so, you know, we have super elastic wires. We can do the same thing as you do with Damon. But if you put them in different bracket systems, different force systems, you're going to have different effects, right? How do we know that? That was published in European Journal of Orthodontics. I want you to look at it. The elastic ligation may act as a restraint on NiTi by limiting superelasticity. And how do they show that? So here's the 4 graphs. This is no ligation. That's what your force deflection curve should look like. That's a normal hysteresis. Look at stainless steel ligation, and look at, self-ligation, and then stainless steel. Similar, right? Damon is the best. But look what elastics do to a superelastic wire. Look at that hysteresis. Totally distorted. So elastics for the first week or so affect the properties of superelastic wires. Why did I say the first week or so? Because that's how long it takes for them to deteriorate and loosen up. Once they loosen up, then the wire is going to behave a little better. But you create side effects in that first week that you don't want. Situation mechanics. Now, let me just emphasize that point before we go to lunch. How many people think adult cases take longer to treat than kids' cases? Raise your hands. Nobody? In my practice, for years, we charged more for adults all the time because they were tougher cases. They always took longer than the kids. Did you ever wonder why? Because it doesn't happen that way in Damon. Now with passive self-ligation, my adults usually treat faster than the kids because they're usually better patients. What was the difference? That bothered me for a long time. And then I finally figured it out, looking back after case to see what was the difference in my cases back then. And you know what it was? Clear brackets. Sounds dumb, right? Why do clear brackets cause more time in adults? Because if you're an adult, right? Okay, let me pick on somebody else. I'm picking on you too much. If you have clear brackets on your teeth, all right, and you go out to dinner and have a glass of wine, what happens to your elastics? They stain. So guess who you call? Monday morning, you call me and say, I need my rubber bands changed. They're pink. You go to work. 3 days later, they're brown because you're drinking too much coffee. Call the office, get your elastics changed. That's what we did in adults. We kept retying and retying and retying, so they always got fresh elastics. And then we wonder why they took 30 and 36 months to treat. Because all we kept doing is adding friction. If the elastics stretched out and ran the same as kids who never brushed their teeth and let them deteriorate, right? Then the teeth moved easier. So we kept, it took me, I couldn't figure that out because all of a sudden my Damon cases, adults were treating in the same amount of time and many times in less time. Made no sense. I was always blaming bone density. It wasn't bone density, it was us. Tying the teeth and retying the teeth. I was retying adult teeth 4 and 5 times the amount that I was tying kids' teeth. That's what took longer. You know, one day you just figure it out. So everything happens by accident. We'll talk more about accidents on Friday, how we learned by mistakes. All right? So, situation mechanics. This is what, before we break for lunch, we'll break for lunch. Remember this. You need a small diameter wire. You need this light force because it drops off, and a large tube to minimize binding friction. And that's what's going to give you the kind of results we need. That's what is going to allow muscles to impact your case, to help you treat those cases. And that's the key slide you should take away from this morning. Big tube, small wire. Least amount of binding, least amount of friction. All right? Have a great lunch. We'll see you back after. All right, we're going to be back promptly, I think, at, I don't know. Is it 1 o'clock? Anybody? 1 o'clock or 1:30? 1 o'clock, right? Okay, we'll see. So eat fast. Get indigestion and then come. No, I'm only kidding. All right. Make sure you're back by 1 o'clock because we got a lot to cover.